David Garcia is here. He is a professor of medicine at the University of Washington. A hematologist, he is the immediate past president of the Anticoagulation Forum, a U.S. national interest group of anticoagulation providers. His primary research interests include cancer-related thrombosis, the treatment of Warfarin-associated coagulopathy, and periprocedural anticoagulation. He is a well-known author and has authored articles in highly regarded journals such as Blood, Archives of Internal Medicine, the New England Journal of Medicine, and Circulation. Today he's going to talk to us about anticoagulation strategies in stroke. Thank you, Dr. Garcia, for being with us.
Well, thank you for that introduction and for inviting me to present as part of this Cleveland Clinic series on stroke. I will be talking today about stroke prevention in patients with atrial fibrillation. My potential conflict of interest disclosures include the fact that I have been an occasional consultant for several manufacturers of the new target-specific oral anticoagulants, and I will be discussing these medications during my presentation, so the audience should be aware of this conflict of interest. With respect to learning objectives, it is my hope that at the end of the presentation you'll appreciate the importance of stroke and bleeding risk assessment in all patients with atrial fibrillation, that you will understand key differences in the options that are now available to us for the pharmacologic stroke prevention in patients with AF, and that you would be able to consider reasons why a clinician might choose one particular anticoagulant option over another. So let's start with a case. And here I describe a 69-year-old woman with a history of hypertension and diabetes who presents with a rapid, irregular pulse and is found to have atrial fibrillation. She has no evidence of underlying valve disease by examination or echocardiogram, and you attempt to estimate this woman's annual risk of stroke, assuming she receives no antithrombotic therapy whatsoever. Is it A, 1%, B, 2%, C, 4%, D, 8%, or E, none of the above? Well, the correct answer is about 4%, and I want to spend the next couple of slides talking about evidence-based ways in which we can try to assign or estimate a particular stroke risk to a patient like this one who presents with newly discovered atrial fibrillation. As many of you probably know, it's been a number of years ago now that the so-called CHADS score was described and published by Brian Gage and colleagues, and it is a simple bedside tool that allows us, based on the presence or absence of several patient characteristics, to roughly estimate an individual's risk of ischemic stroke with atrial fibrillation. This score has been slightly improved upon, one could say, with the so-called CHADS VASC score that I show in this slide, which adds a few additional clinical variables and simply allows us to estimate stroke risk in a slightly more granular fashion for our patients with atrial fibrillation. You can see that the elements of this score incorporate the presence or absence of congestive heart failure, high blood pressure. It divides age into two categories, those over 75 and those in a more intermediate risk category between 65 and 74. The presence or absence of diabetes, prior history of stroke, transient ischemic attack or thromboembolism, the presence or absence of vascular disease, and a patient's sex. It turns out that women are at somewhat higher risk for stroke than men. In this slide, we see that as the CHADS VASC score, shown in the left-hand column, increases, the patient's annual likelihood of stroke, shown in the far right-hand column, also goes up. And really, we see that for patients who have a CHADS VASC score that's more than 1 or 2, certainly, the stroke risk can be quite substantial. The patient in the case I presented would have a CHADS VASC score of 3, based on her clinical characteristics. And you see here in the right-hand column that corresponds to an annual risk of thromboembolism of over 4%. Well, let's go back to our case. For a patient with a CHADS-VASc score equal to 3, such as the woman we described earlier, the likelihood that the risk of anticoagulant-related bleeding will outweigh the benefit of anticoagulation is A, high, B, intermediate, or C, low. So the likelihood that the patient will have more risk than benefit from anticoagulation is which of these categories? Well, if you answered C, low, I agree with you. And I think this is a principle that applies to most clinical decisions about anticoagulation in patients with atrial fibrillation. In the vast majority of cases, the risk of anticoagulation, while real, will likely be greatly outweighed by its benefit. Well, why do I say that? There are ways that we can quantify or at least come up with semi-quantitative estimates for bleeding risk in patients with atrial fibrillation. And here I show you 3 different clinical risk prediction models or scoring systems that have been devised for this purpose. You can see that these scoring systems are somewhat complex. They involve a lot of clinical variables, and particularly in the case of the hemorrhages score on the right-hand side of the slide. But you should also notice that there are a number of recurring themes. For example, hypertension or poorly controlled blood pressure appears in all of these scoring systems as an independent risk factor associated with anticoagulant-related bleeding. Similarly, advanced age and anemia seem to have a strong association with an increased risk for anticoagulant-related bleeding. And not surprisingly, poorly controlled INR values is also an independent predictor in some models. Well, in my clinical practice, I don't necessarily try to remember any one of these bleeding risk scores, but rather I try to keep the individual strong predictors of bleeding in the back of my mind because some of them are modifiable. Why do I not think it's critical to remember or specifically calculate a bleeding risk score for most patients? Well, because when you do, what you find out is that most patients go into the low-risk category. Let's take a look at this study of a large cohort of patients, over 2,000 patients, for whom the bleeding risk score was calculated using all 3 of these models. If you look in the second column from the right, labeled all patients, you see that whether you use the hemorrhages model, the has-bled model, or the atria bleeding score, somewhere between 75 and 90% of patients in this cohort were classified as being at low risk for bleeding, and a distinct minority of patients were in the highest risk of the bleeding categories. So without knowing anything else about a particular patient with atrial fibrillation, we can say that it's statistically likely that they're going to have a non-trivial risk for ischemic stroke and be in a low bleeding risk category. Now, certainly there'll be some exceptions to this rule that the vast majority of patients will benefit from anticoagulation. For example, a patient with a CHADS-2 score of 0 or 1, particularly if the CHADS-VASc score is also low, might be patients where we really want to look carefully at the bleeding risk, because if it's anything more than trivial, one could argue that the burdens and hazards of anticoagulant therapy are not justified. But for pretty much all other patients, that is, patients whose CHADS-VASc score exceeds 2 or 3, or CHADS score is 2 or greater, I think we have to think really hard before withholding anticoagulant therapy because irrespective of what the bleeding score yields when you calculate it, it's very likely there'll be a net benefit from anticoagulant medication in such patients. What we can do with these bleeding risk scores, though, routinely, is identify modifiable bleeding risk factors in our patients. By showing independent associations with the risk for major hemorrhage, these scores remind us that we need to control blood pressure. In patients where we use warfarin, we need to improve INR control. And whenever possible, we should discontinue concomitant antiplatelet therapy, since it is an independent factor known to increase the risk of major anticoagulant hemorrhage. Well, let's return to the case again. The patient has become aware of some of these newer so-called target-specific oral anticoagulants like Dabigatran, rivaroxaban, and apixaban, and she would like to discuss the pros and cons of using one of these agents as opposed to more traditional therapy with warfarin. Which of the following statements is not accurate regarding this class of medications? With the novel oral anticoagulants, A, the risk of fatal bleeding is higher than with warfarin. B, the risk of intracranial bleeding is lower than with warfarin. The risk of ischemic stroke is equal or lower compared to the risk with warfarin. Or D, the likelihood of dietary and drug interactions is lower compared to the likelihood with warfarin. Well, if you answered A, that is, you said that it's false to state that the risk of fatal bleeding with the novel oral agents is higher than the risk of fatal bleeding with warfarin, you're correct. Indeed, the opposite is true, and I'll go through that in the subsequent slides. First, though, let's remind ourselves about some of the unique pharmacokinetic features of these so-called target-specific oral anticoagulants. In this chart, we're looking at the three agents that have now been approved to prevent stroke in patients with non-valvular atrial fibrillation in the United States, and we see that apixaban and rivaroxaban are both direct inhibitors of activated factor 10, while dabigatran is a direct inhibitor of thrombin, or activated factor 2. You can see that they have their maximum anticoagulant effect, or peak mechanism of action effect, approximately 2 hours after a tablet is swallowed. Very different from warfarin, which doesn't achieve its full anticoagulant effect for several days after the medication has been initiated. You can see that protein binding is somewhat variable. It's quite high for apixaban and rivaroxaban. That has implications for patients where we may want to urgently remove the drug. We can do so to some extent for dabigatran by using hemodialysis or hemofiltration. On the other hand, that's fortunate because dabigatran is the drug that is most dependent on renal clearance. So while we should be careful using any of these drugs in a patient with marked or severe renal insufficiency, dabigatran depends so much on kidney function being normal that I think even modest decreases in renal function should give us pause when considering the prescription of dabigatran. Well, let's consider the types of bleeding that we see in all anticoagulant treated patients and compare these novel agents as a class to warfarin. I'm showing you here a forest plot from a meta-analysis of the large atrial fibrillation studies involving not just the three agents we've discussed up to now, but also a fourth agent called edoxaban. And in this pooled analysis of data from almost 30,000 patients, we see a very consistent and convincing effect that these novel agents appear to reduce the risk of intracranial bleeding, the most dreaded complication of anticoagulant therapy, by about 50% compared to the risk with warfarin. Luckily, intracranial hemorrhage is a rare event, but when it happens, of course, it's devastating. And I think it's important to take note of the fact that these newer medications do reduce the risk of this dreaded outcome. On the other hand, as a class, these medications cause a somewhat increased risk in gastrointestinal bleeding. It's probably about a 25% relative risk increase that does barely reach statistical significance when one pools the data for all of the agents. But I should add that depending on the individual agent and the dose at which it was studied, the effects on gastrointestinal hemorrhage versus warfarin is somewhat variable, and I would refer you to the individual clinical trials and information about the individual medications to study that further. But let's talk more about this issue of fatal bleeding. In this table on this slide, I'm showing you data about outcomes of patients who suffered major bleeding in the randomized controlled trials that were done comparing dabigatran to warfarin. And I want you to just focus on the first two rows of this slide. Those who wish to review it in more detail can pause and do so. But the first two rows of this slide show mortality in the randomized controlled trial among the patients treated with dabigatran and those treated with warfarin. And remember, we're looking only now at the patients who suffered a major hemorrhage during the study. And among these folks who suffered a major hemorrhage on either dabigatran or warfarin, we see that whether you look at 5-day outcomes or 30-day outcomes, there is a decrease or a strong trend toward a decrease in total all-cause mortality. Similar data have emerged from the ARISTOTLE trial comparing apixaban to warfarin. Here we are looking at Kaplan-Meier plots which demonstrate the proportion of patients on the y-axis who reached a pre-specified endpoint defined as major bleeding followed by death within 30 days. You can see that this endpoint was reached by only 0.5% of patients on apixaban at 30 months of follow-up, while the proportion of patients treated with warfarin who reached this endpoint of major bleeding followed by death within 30 days was reached twice as often. So I think we now have a fair amount of data suggesting that fatal bleeding is not more common in the patients treated with the novel or target-specific oral agents. To drive this point home, I just want to show you finally now a table in which I have aggregated raw data on fatal bleeding for warfarin or standard therapy in the second column from the left, and among the patients on the target-specific anticoagulants in the third column from the left. And you can see that whether we're looking at the atrial fibrillation stroke prevention studies, which are colored blue in the far left-hand column, or the venous thromboembolism treatment trials, which are colored red, there is either a statistically significant or non-significant numeric trend favoring the target-specific oral anticoagulants for this endpoint of major bleeding in every single one of these phase 3 prospective randomized controlled trials. So not only is it false to say that fatal bleeding is more common in patients on the target-specific agents, in fact, the opposite is true. It's less common than it is with warfarin. Well, based on all this sort of information and the fact that it might be more convenient for him, the patient decides to start therapy with apixaban 5 milligrams twice daily. She asks whether she should come in for routine coagulation testing as her older brother who takes warfarin does. Which of the following is not an accurate statement about this class of medications as compared to warfarin? The novel agents are A, approved for use without routine coagulation monitoring, B, can be monitored with traditional tests like the prothrombin and partial thromboplastin times, PT and PTT, have a prolonged half-life in patients with renal insufficiency, or D, have expected plasma concentrations that will depend on when the patient took their last dose. Well, the correct answer here is B. In fact, as I'll show you in the next slide, while partial thromboplastin times and prothrombin times may reflect the anticoagulant effect of these target-specific agents. They cannot be reliably used to monitor or measure the effect of these drugs because the assays are affected inconsistently. Here's a table demonstrating the inconsistent effect of these novel oral agents on traditional clotting times. And it's a busy table, but what I want you to take away from it is that when it comes to the PT and the PTT, which are shown in the second and third columns from the left respectively, the effect on these tests for the various agents is inconsistent. Indeed, for apixaban, it's not at all uncommon to have a completely normal PT or PTT, even with nearly therapeutic concentrations of the drug present in the plasma. Now, there are some reagents and some particular laboratories that can detect even low levels of one or more of these target-specific agents using one or more of the traditional clotting tests. But you would have to check with your own specific lab and ensure that they have adequate sensitivity with the reagent and instrument that they're using before you could reliably interpret a PT or PTT in a patient taking one of these new drugs. Instead, what we suggest is that if you have an occasion where clinically it makes sense to measure the effect of one of these agents, you should probably use, in the case of dabigatran, a dilute thrombin time, or in the case of rivaroxaban and apixaban, an anti-factor Xa activity, particularly that's been calibrated, an assay that's been particularly calibrated for one of these drugs. Well, lastly, I'm frequently asked which atrial fibrillations are good candidates for the new target-specific oral agents and which ones might be better candidates for warfarin. So I wanted to spend a little bit of time going over this in these last couple of slides. I think patients who either find INR testing burdensome or, despite adherence to their provider's recommendations, have a really low time in therapeutic range are great candidates for these drugs if they can afford them. Now, patients who are non-compliant or are going to have a hard time acquiring the new medications because of financial or insurance reasons are not good candidates for these drugs. But if a person has normal renal function or renal function that's not severely impaired for rivaroxaban and apixaban, I think they're excellent candidates for these agents, provided they can get access to them. On the other hand, patients who have advanced renal insufficiency are not good candidates for the target-specific agents because they all depend to some extent on renal clearance. I think we have to really think carefully about the risk-benefit of any anticoagulation therapy in a person with significant or severe renal dysfunction, and that's a whole other subject altogether. But suffice it to say, the principle applies to warfarin as well as the novel agents. I think a person who's been on warfarin doesn't find INR testing to be particularly burdensome and has had consistently therapeutic INR values is a person who would probably do just fine staying on warfarin therapy and would not be the first person I would choose to prescribe these novel agents for. Patients who have access to self-testing instruments and are comfortable doing their own INR measurements and can maintain high time in therapeutic range using some form of home testing or home monitoring, I think are also really good candidates to just stay on warfarin or initiate warfarin if that's what they prefer. And then, while I didn't go into it today very much, there are some selected drug-drug interactions that are clinically relevant for these novel oral anticoagulants, and I would suggest that you check with your local pharmacist about this in a patient who's taking a lot of medications and for whom you're considering prescribing a target-specific drug like rivaroxaban, apixaban, or dabigatran. And obviously, a patient who is taking one of these rare medicines that has the potential to react in a clinically significant way with one of the novel agents would not be an ideal candidate for one of these newer medicines. And then finally, obviously, there are simply patients and physicians who prefer to use more traditional therapies that have been around for a longer time, that have a longer track record, and I think that's a perfectly legitimate reason or rationale to use or remain on warfarin therapy. I'd just like to point out that I have not included on this slide the lack of an antidote or lack of a reversal strategy as a reason to choose warfarin over one of the novel agents. While it's true that the novel target-specific oral anticoagulants do not have an evidence-based reversal strategy or specific antidote which is currently available in the U.S. market, such antidotes are being developed, and based on the fatal bleeding data I showed you earlier, I would argue that if anything, we're likely to avoid hazardous or devastating bleeding outcomes by using these drugs, even without an antidote being available. Well, I'll conclude now by saying that for most patients with atrial fibrillation, the risks of anticoagulant therapy will be outweighed by the benefit of anticoagulant therapy. In patients where it's a close call, because the stroke risk is particularly low, these scoring systems that we talked about earlier can be useful to help providers quantify the risk of bleeding versus the risk of stroke, and I would hope in some cases perhaps at least consider steps that could be taken to modify or reduce the risk of anticoagulant-related major hemorrhage. One step we can take to reduce the risk of intracranial and probably fatal bleeding is to use one of the novel or target-specific agents rather than warfarin. But if we're going to use these drugs, we need to be familiar with the fact that they have important pharmacologic differences from warfarin, and while they are at least as safe and effective as warfarin to prevent AF-related stroke, they're not the right choice for every single patient, and understanding the particulars about how they can be used safely and in which patients they're going to be best used and most effective is critical. Once again, thanks for inviting me to give this lecture, and I've enjoyed participating in this Cleveland Clinic Grand Round series on stroke.
Thank you, Dr. Garcia, for this thoughtful and thorough discussion. The incidence of atrial fibrillation is estimated to triple over the next few decades, so effective treatment strategies for this process are going to be paramount as we move forward. These new anticoagulants are going to be under continued scrutiny. I hope you have found this useful and would stay tuned for late-breaking evidence in this growing area in the treatment of atrial fibrillation. Thank you for listening.